Hello, my name is Dr. Dewan as Raja. Today I will discuss about Bell palsy. Bell palsy is a very important topic, and this is the lower motor neuron lesion of the facial nerve. So what happened in Bell's palsy? Acute isolated unilateral facial paralysis. So one-sided paralysis, entire side, same side paralysis. Cause is mostly unknown. Maybe some type of herpetic infection, some viral infection, maybe some type of trauma, but we don't know the exact cause of Bell palsy. Unilateral involvement of the facial nerve may have partial or complete resolution by 1 month. Around 80% cases, it will be completely okay, even without any treatment. Okay, we got that. Now go to this image is so important to us, we must know that part. Okay, let's start one by one. So this person has Bell's palsy due to dysfunction of the facial nerve, typically causes paralysis or weakness of the muscles on one side. So this side muscles are paralyzed in this person, not the other side. That is normal side. This is the paralyzed side. What happened? Okay, so if you look at that, he has inability to furrow the brow on the affected side, so the upper part of the face also involved. That is, that doesn't involve in case of supranuclear facial palsy or cortical lesion of the facial nerve, upper motor neuron lesion of the facial nerve. This part is spared. But in case of Bell palsy, that is a lower motor neuron lesion, so it will involve the entire face. This part is not spared. It is spared in case of upper motor neuron lesion. But Bell palsy is a lower motor neuron lesion, so entire half of the face will have the effect of paralysis of facial nerve. Inability to furrow the brow on the affected side, slight widening of the palpebral fissure, so there may be lacrimation, there may be dryness, both are possible, drooping of the corner of the mouth and loss of the nasolabial fold here, that is lost. So we got that. So we got the Bell's palsy fissure. This is the facial nerve. It comes out of the temporal bone through the stylomasted foramen here. They give the posterior branch to innervate the stylohyoid muscle, the posterior biliary digastric, and 5 branches. One is the going to the temporal region, another going to the zygomatic region, another going to the buccal region, another is the mandibular marginal branch, another is the cervical branch that supplies the platysma. So just by looking at that image, we can assess where is the site of lesion. Okay, this is this is not upper motor neuron lesion, this is lower motor neuron lesion. So we have the lesion that usually in the facial canal, even it may be from the floor of the fourth ventricle to the stylomasted foramen, anywhere there may be lesion. Okay, what happened? Suppose this is the area called geniculate ganglion. We get the greater petrosal nerve to the pterygoid canal. We'll get the deep petrosal nerve. Then we'll go to the nerve to the pterygoid canal. Then we'll get a lacrimal nerve eventually, and it will supply the lacrimal gland. Okay, so any lesion here will cause everything lost, like that of the lack of lacrimation. This lesion will lead to this part, this lead to entire thing will not work, everything will be in jeopardy. Here, suppose there's a lesion here, then lacrimation will not be affected. Okay, but other like that of there will be hyperacusis, loss of taste sensation from the interior two-thirds of the tongue, and also there will be decreased secretion of the salivary gland, and submandibular gland. Okay, there will be paralysis of a side of a muscle, side of the all the muscles of facial expression. So due to lesion here. So suppose here is the stapedius muscle innervates the the middle ear cavity. Okay, stapedius, it is attached to the stapes, the middle ear cavity. So it is very important. If this nerve is lost or damaged, then there will be hyperacusis. Okay. Then if we go further down, if there is any lesion here, what will happen? No problem in the lacrimation. There will be no hyperacusis, but certainly motor function of this side of the face will be lost, and the secretory motor function of the salivary gland like submandibular, sublingual, too, not the parotid. These two gland secretion will be disturbed due to a section here, plus no taste sensation from the anterior two-thirds of the tongue. We call it aguitia due to the damage to the taste fiber from the anterior two-thirds of the tongue except the basal papillae. That is the sensation carried by the chorotympani branch of the facial nerve. This is the chorotympani branch of the facial nerve. So if there is a lesion here in the stellamastoid foramen, there will be no loss of taste sensation, no dysfunction of the salivary gland, no hyperacusis, no dysfunction of the lacrimal gland. So that does not be those will not be affected if there is a lesion here. Okay, we got that. Now we'll go to the next slide here. Clinical features of Bell's palsy characterized by asymmetry of one side of the face. We have seen in the previous picture. Eyelid not closing completely because the orbicularis oculi muscle is paralyzed. That is a muscle of facial expression. Drooping of the lower eyelid, again due to the lack of function of the lower eyelid muscle. Around that we have the orbicularis oculi muscle that is paralyzed. So there will be droop down of the lower eyelid. Drooping of the corner of the mouth, again muscles of facial expressions are paralyzed. Loss of nasolabial fold, same thing happen because of lack of nerve supply to the muscles of facial expression. Food and saliva may pool in the affected side of the mouth. Okay, that may lead to bad oral hygiene. Feeling of facial numbness. Facial sensation is intact because that is carried by the trigeminal nerve. Okay, loss of blink reflex, yes, afferent component is okay, but the efferent component will be lost because there is no nerve supply to the orbicularis oculi muscle in case of Bell's palsy. Okay, so loss of blink reflex. Following feature may be present: hyperacusis because due to the paralysis of the lack of nerve supply to the stapedius muscle, decreased lacrimation, decreased taste, we just discussed that part, increased intensity of sound, we call it hyperacusis, especially a person when he receives or when she receives a telephone call, the patient will complain a very loud sound, too much intensity of the sound. Okay, that may happen in certain percentage of the population. Okay, here post auricular pain that may happen like this may be associated with herpetic blister affecting the outer ear canal and area behind it. We call it Ramsay-Hunt syndrome. This is a herpetic blister affecting the outer ear canal and area behind ear. Pathophysiology, again, cause is not known. Inflammatory reaction that compress the facial nerve may be reactivated by viral infection like that of the herpes zoster, herpes simplex. Facial nerve is inflamed and compressed against the narrow facial canal walls. There may be demyelination of the facial nerve. Okay, we have some differential diagnosis. This is a clinical diagnosis. We may have a tumor. Okay, there may be head injury, that may also lead to the features of Bell palsy. So treatment and disposition, it should be treated by a registered licensed physician like neurologist, otolaryngologist, or primary care physician. What we need to do, protection of the eye, because eye is open, lower eyelid going little down. Okay, so there may be dryness of the cornea, there may be keratitis may happen if we do not take care from the very beginning. Artificial tear should be installed frequently, and the lid should be taped closed at night. Okay, that is very important. Okay, so so oral hygiene is very important. There should not be any food deposition between the teeth and the cheek that may lead to stomatitis. So oral hygiene should be maintained. We may also get help from a hygienist. Steroid is important medication that will decrease the duration of suffering, and prednisolone. Okay, we know that there are a lot of adverse effects of steroid like moon face, buffalo hump, central obesity. You have to know the, the adverse effect of prednisolone, or even when other steroid. Acyclovir, that is a viral drug, antiviral drug. Okay, all patients should be referred to a neurologist, otolaryngologist, or primary care physician. Okay, these are my references. So please share the information with your friends. And if you have any question, please feel free to ask me. And have a nice day. Bye now.